All right, so welcome everybody. Welcome back to Garfunkel Wild's compliance webinar series. We have another great webinar here for you today. And we have an interesting topic, I think, for a variety of both providers and others. So I'm sure many of you know that there's been a significant growth in managed care over the past few years, and it's certainly shifted how the government covers healthcare for its beneficiaries, particularly Medicare beneficiaries, as well as how it pays for it. Looking at the OIG's website, you can see some of the graphics there and some of the numbers you see from 2007 to 2023. It went from 19% to 54% of enrollees receiving their care through Medicare Advantage plans. So what does that mean? Well, when the government's moving their money into other directions, it's time for them to adjust all of the their focus and their audits to monitor and ensure that they have appropriate oversight. And that's what we put together a great panel for you today to discuss those things. And I'd like to introduce my colleagues who and my friends here. Joining us, this is a kind of nice marriage of compliance and our managed care groups. Joining us is Deb Silverman, who is the chair of Garfunkel Wild's Managed Care Practice Group. If you're doing anything in managed care, I'm pretty sure you know Deb, and you probably have come to know Allison Schimmel, who joined us a few years ago and handles a variety of regulatory matters and is certainly an expert also in managed care contracting and healthcare delivery models. And joining them is my partner, David Trasky, who has joined us a few years now and bringing really the OIG perspective. David was senior counsel with the United States Department of Health and Human Services, Office of the Inspector General. So we have, that kind of inside look here today. Just a couple of housekeeping things, and I see them popping up in the chats. The video is being recorded. The slides will move when we start going through them. So I see you to answer some of the questions there. And at the end, when this is all complete, we will be, if you are registered and we have your email, you will get a copy of the presentation and the slides emailed directly to you. So thank you all for joining. Thank you to my colleagues for putting on this great presentation. We have more coming from Garfunkel in our webinar series. So look out for that. We'll be blasting you soon with our next one. And so please, we'll be doing that May 1st, and we'll be talking about, a New York OMIGS 2024 work plan and things you need to be preparing for. So with that, Deb, David, Ali, take it away. Thank you.
Hi, everybody. I think we passed quickly through our disclaimer. Ali, why don't you just put that up on the screen for 2 seconds, just letting everybody know we're not giving legal advice, we're providing education for you, and you should not be relying on any one of us for specific legal advice. You should get that from qualified counsel, although we do think we are qualified to provide you with legal advice if you so choose. On today's agenda, we're going to be talking about, David's going to talk about HSS, the OIG strategic plan overview, its impact on providers, and we're going to focus specifically on the 2 midnight rule, risk adjustments, and voluntary self-disclosures. So with that, I'm turning the mic over to David, who'll start us off.
Thank you so much, Deb. I appreciate it. Thanks everybody for joining us this afternoon. Before we get into the substance of the program, I would just say one of the big questions that I get routinely after coming from the OIG into private practice is, what's the OIG going to do next? Where are they going to devote their energy and their resources next? And so today, we're going to talk a little bit about managed care because that is the sort of the next frontier or the next priority for OIG. And as Rob mentioned, as you can see from the graphic here, 54% of Medicare enrollees received care through an MA plan last year. But I think, that only really tells part of the story. In the last 10 years in particular, the amount of annual expenditures to Medicare Advantage has risen from $147 billion to last year it exceeded $450 billion. So that's a huge 3x, multiple in terms of growth. And from when the OIG sees that type of growth in a particular sector or a particular area, naturally they would associate increased growth with an increased risk of improper payments, right? And so that's why you will see today that OIG has sort of unveiled this strategic plan overview specifically focused on Medicare Advantage. All right, and so I think before we dive into it, the other thing I would say is if you take nothing else away from this, I would love for you all to just sort of remember one thing, which is to be thoughtfully proactive, right? Thoughtfully proactive in making sure that your compliance programs and policies and procedures and things of that nature are functioning as they should, because it's always great to sort of have those things in order, certainly before the government comes knocking. All right, so with that, Allie, if you wouldn't mind going to the next slide, thank you. So oftentimes when OIG identifies a priority area, it's sort of couched in this idea that there's sort of three main things that they're always sort of looking at. One is to promote financial stewardship in the program, to provide access to high quality and safe care, and to hold providers and plans who are engaged in misconduct, to hold them accountable, right? And what we see here is that some of that work is already happening even prior to the rollout of this strategic plan overview. In particular, and Allie's going to touch on this later on in the presentation, the OIG has identified sort of two areas in particular that are going to sort of be high on their list of things to be looking at. One of them relates to sort of risk adjustments and overstating the sickness level, if you will, of the enrollees, so that the plans can receive more money. And then also another area that was recently discussed as recently as yesterday by IG Christy Grimm in her testimony before the U.S. Committee on Energy and Commerce, is durable medical equipment. So in the last couple of years, in the last 3 years, billing for DME has gone up 59%. And so these are some of the things that are sort of happening in the background, and it's these types of things that motivate OIG to put a greater focus on Medicare Advantage. And given the complexity of the managed care, what you'll see is there's going to be a concerted effort among these various components within OIG. And it's going to look a little bit different, or it'll look a little bit, there's going to be a couple different ways that you might sort of get touched by OIG in this way. It could be from their Office of Investigations. It could be from their Office of Audit Services, their Office of Evaluation and Inspections, or the Affirmative Litigation Branch. And we'll talk a little bit about sort of how those sort of play together and what you might see. Allie, if you wouldn't mind, the next slide, please. So when we talk about this sort of alphabet soup of different components within OIG and how they all work together, certainly I think what you'll see is the strategic plan. When you review it, you'll find that it's generally focused on the plans, but there's an important impact to providers on that, and it sort of looks a couple different ways. Sort of based on my experience, what you'll see is now that this has been identified as a strategic area of importance, you'll see an uptick in work done by the Office of Audit Services and the Office of Evaluation and Inspections through various audits and reports and things that they'll issue. They also work collaboratively with the Office of Investigations to look at matters for criminal or civil prosecution, and they also work with the Affirmative Litigation Branch for matters that maybe don't rise to that level of prosecution, but maybe have an administrative remedy. So there's a couple different ways. The first way that you might see it is that if you're a plan, you might have one of those entities reaching out directly to you, either as part of an audit, part of an investigation, something of the like. If you're a provider, you may also experience that same thing. Or what you might find is that if one of these entities reaches out to the plan may then sort of shift the risk or ask for information from the provider to be able to respond to an OIG inquiry. So there's a couple of different ways that providers are going to be impacted by that. Like I said, whether it's with respect to a direct outreach or sort of kind of as more on a downstream basis in response to some action that's being pursued against the plans. All right. The other thing I think that's important to know is that they're going to be looking at those three. I know there's 4 bullet points there about what their focus is going to be on. I'd say those points 2, 3, and 4 are probably sort of the most likely as far as it relates to providers. OIG is sort of constantly on the lookout for making sure that both the providers who are enrolled in the program or in the plan, as well as the patients and the beneficiaries, to make sure that they're weeding out people who would otherwise be ineligible or untrustworthy. So I would expect that this would sort of continue on. And OIG's been doing this for some period of time, right, covertly, in the sense that it hasn't been given sort of the same level of importance than it has been. I think historically speaking, Medicare managed care and Medicaid managed care, sort of those programs have been taking a little bit of a backseat to fee-for-service programs, but I think that's going to be changing based on this strategic plan that's been trotted out. And I think too as well, the other thing that I would really love to sort of convey to the providers in particular is that OIG has a tremendous amount of data to which they have access. It's actually quite mind-boggling, in fact. And so as the healthcare sector grows, and as does the amount of data that is collected by plans and providers who participate, in those things, OIG is leveraging that data to be able to identify outliers in providers and in plans and things like that. So this is part of their sort of overarching new approach to use data in a way that allows them to be more proactively looking for potential red flags or outliers or things of that nature. And the reason for that is because it's more efficient, right? In the sense that the OIG has a limited number of resources, and so they're going to be trying to devote their resources to those areas that sort of give them the biggest bang for their buck.
David, I'm sorry, David, let me just interrupt you for 1 second. I'd like to ask you a question about that.
Sure,
Do you foresee the OIG, let's say through their data analytics, they see a problem with certain types of DME reimbursement or whatever? Would they then clue in the MA plans, who would then each plan go out and do their own audits of their participating providers? Is that a possibility?
Yeah, I mean, I think that's a possibility. I think that historically OIG, if they see issues with a provider, they'll sort of look at those on their own right. And I'm speaking again from the affirmative litigation branch, sort of which is where I came from. But what you may see is if it's the subject of an audit or an evaluation, that might be something where the OIG would identify, like in your example, might identify some issues with DME. They would reach out to the plan to get some additional information, and then they would likely issue a report that's more sort of general in nature without identifying a particular provider or plan. about some shortcomings that they've identified through through their audit work or through their evaluation work. On the other side, when you're looking at, the Office of Investigations or the administrative or the affirmative litigation branch, those are the types of entities that, like I said, they're going to be looking at, criminal and civil and administrative prosecution. And those are the folks that are going to sort of key in more on a particular provider or a particular plan or something to that effect.
Thank you. That's helpful. I
Sure.
also just want to give a public service announcement for the providers on the call. Remember, Medicare Advantage has a 10-year look back requirement that you maintain all your data for at least 10 years in relation to your Medicare Advantage contracts. So it's 10 years, which is longer than pretty much anything else out there. And if you do get a request from a health plan, your contracts require that you comply. If you're not sure what it is, you can always show it to someone and say, hey, does this make sense? Are we subject to an audit? Are we just providing information that the health plan needs to provide over to the OIG or to CMS? But again, you do have strict requirements in your contracts when it comes to responding to requests for information from the MA plans. Sorry, David, go ahead.
No, that's great. No, it's a good reminder. And to your point, sort of to the point of one of the other things that IG Grimm had said yesterday in her remarks that caught my attention was that she was interested in having the OIG partner with plans to sort of crack down on misconduct, whether it's particularly as it relates to payments and services. And although there's this, on one hand there's this tension, right, because she talks about partnering with the plans, but sort of on the other hand, ultimately we know that the plans and by extension the providers could be then subject to being held accountable. So like I said, generally speaking, OIG is going to sort of focus its efforts most likely on sort of where the evidence or where the data leads them. And they're going to sort of take a risk-based approach. For example, I know that in the past, they've looked at things like duplicate payments or claims or services that are being provided to deceased enrollees, right? So, and those are all things that can be sort of gleaned from data, among other topics. So you'll see too as well that some of these issues have come up repeatedly over the years for the OIG. And they may look at them and then there's a lull for a couple of years and then they sort of go back to it. And that's really just because there's, that OIG is continually finding that there's deficiencies or shortcomings in the way that certain things are being done. So they're just going to sort of sit on that and stay on it and make recommendations to try to improve it. But that's sort of why you would see sometimes they keep coming back to the same issues over and again. Okay, next slide.
Okay, so this is my turn. We're going to talk a little bit about the 2 midnight rule because it's part and parcel as to HSS's plan to promote access to care for MA members. So now CMS is requiring MA plans to follow the 2 midnight rule and the Medicare inpatient only list when it comes to coverage of inpatient admissions. The Medicare inpatient only list, as many of you know, is a list of procedures that states that Medicare will pay for when care takes place in a hospital inpatient setting. Back in 2020, there was talk that CMS would be phasing this list out, but to my knowledge, this has not occurred. And now MA plans must cover these procedures for their members when performed as hospital inpatient. There's no debate here about coverage, but it's not so simple when it comes to extending Medicare's 2 midnight rule to Medicare Advantage members. Under the 2 midnight rule, CMS created a benchmark for coverage under Medicare Part A, which covers hospitalizations, which provides that a patient is eligible for inpatient care if the admitting physician expects the patient to require hospitalization for at least 2 midnights. But there is one key difference between the 2 midnight rule with respect to how it plays out under fee-for-service and how it's going to play out under Medicare Advantage. Under fee-for-service, there is a presumption that if the patient's stay spanned 2 midnights, the admission was medically necessary, and Medicare contractors need not audit these admissions, unless, of course, there's a suggestion of gaming or a delay in care. However, CMS specifically rejected this 2 midnight rule presumption with respect to MA plans, noting that MA plans may audit any inpatient admission of their choosing to ensure that the 2 midnights of hospital care were medically necessary. CMS also did not prohibit MA plans from using evidence-based criteria used for commercial patients, such as MCG, which is the old Milliman Care Guidelines, or Interqual, to assist with determining medical necessity of hospital inpatient admissions. Only in the case of an admission to a skilled nursing facility or to an inpatient rehab facility did CMS state that it would be improper for MA plans to use commercial criteria in place of Medicare guidelines. I should also note that CMS made clear that MA plans must not only follow this 2 midnight benchmark, but also the case-by-case exception when 2 midnights are not expected, but inpatient care is nonetheless necessary based on complex medical factors that should be documented in the medical record. So what does this mean for hospitals that participate in MA plans? Absent any protective language in the hospital's participation agreement with the plan, the hospital is subject to the plan's rules with respect to utilization review and payment of inpatient claims. That could mean both prepayment review of submitted claims, which includes having the claims pended and requests for medical record, or post-payment review of paid claims and possible level of care denials and recoupments, if the plan believes that the inpatient admission was not medically necessary. So what can hospitals do? All hospitals can and should provide education to its admitting physicians on how to properly document the physician's decision to admit the patient. But charting, I anticipate that the patient will need to stay in the hospital for 2 midnights will probably not carry the day. But writing a note that provides the clinical basis for the physician's assessment that the patient is expected to need to be hospitalized for 2 midnights should. For example, if a physician writes, "I expect the patient to remain in the hospital for 2 midnights as a result of the patient presenting at the emergency department with an arrhythmia, and that has not improved despite the patient being treated with XYZ drug while in the emergency room," may in fact be sufficient. In addition, hospitals need to evaluate their participating provider agreements with MA plans to assess whether they need contractual protections. Remember, CMS rules and regulations and guidelines set the floor for the relationship between hospitals and MA plans, but not the ceiling. With limited exceptions, the contract between the hospital and the MA plan governs the relationship between the parties. So hospitals should look to negotiate with the plans for protection. This could mean contractually agreeing to apply the 2 midnight rule presumption for MA members, which would be ideal, but that's probably a heavy lift, but it's worth a shot. Moreover, hospitals should try to negotiate parameters on prepayment review and post-payment audits. What is the process for prepayment review? Can the plan access the hospital's EMR system to expedite the review? Does the hospital want to grant them that access? And if they do, what are the ground rules for doing so? How are disagreements handled? Is there a peer-to-peer review? How often can post-payment audits occur? Quarterly, annually? How many charts can be reviewed per audit? Is there a mechanism for an independent third-party review if the hospital and the MA plan disagree on audit results? What about a cap on total denials? How successful hospitals will be with these negotiations will depend on each hospital's market position and its value to the plan. There is no one size fits all. And on that note, I'm going to turn the mic over to Allie, whose topic risk adjustment happened to be the focus of the congressional testimony given by IG Graham. The IG's topic was examining how improper payments cost taxpayers billions and weaken Medicare and Medicaid. Allie?
Thanks, Deb. So yeah, as Deb and David both mentioned, talk about timing. The IG testified yesterday before Congress addressing the department's focus on Medicare Advantage. And specifically, the IG chose to highlight two main areas where HHS has identified significant risk. And of course, the first of those areas was risk adjustment. So to start off with some background, CMS uses risk adjustment to provide higher capitation payments for sicker enrollees. It's just that simple. And they base these risk adjustments on diagnoses that are in encounters or claims data. They're meant to predict costs. So they'll use diagnoses from 1 year to predict the costs in the following year. And this is important to health plans because it's tied directly to the premiums they're getting paid by CMS to care for these enrollees. So this brings us to the Medicare Advantage Risk Adjustment Data Validation Program, which is also referred to as RADV. And these RADV audits are how CMS addresses improper overpayments to the plan by confirming that any diagnoses that the plan submitted for risk adjustment are actually supported in the enrollee's medical record. So as a provider, when you get a medical record request that doesn't seem like it's tied to a payment you got for a service you provided, this is typically what it's about. CMS uses this RADV audit as a way to find any risk adjustment discrepancies. And they identify these discrepancies when the HCCs submitted by the plan are different from those that CMS would assign based on its own medical record review. Now, the problem that's popped up, which HHS identified in a report back in 2021, is plans were reporting diagnoses not necessarily just based on treatment that was being provided to the enrollees, but based on additional things like a health risk assessment or a chart review. So it would make enrollees appear sicker, and then plans would receive higher payments from the government, but this wasn't necessarily translating to additional care to the enrollees. And HHS actually found that plans were consistently overpaid for unsupported risk adjustment payments. They identified approximately $377 million in potential overpayments as of August 2023, which, as you can imagine, they were not particularly pleased about, especially since they're tasked with protecting taxpayer dollars here. So now you know why is HHS focusing on this piece? Why is this a big deal for plans? You'd think, okay, maybe they're just not going to get as big of a premium. No. Back in February 2023, CMS issued in its final rule that the RADV audit can now be extrapolated back to 2018. So that's 6 years that these plans can now be on the risk for overpayments. That's a huge increase in their risk, and obviously is a huge reason why they want to downstream as much of that risk as possible to providers. Okay, so how are they trying to downstream this risk to the provider? We've already seen certain MA plans are strengthening their contractual language when it comes to RADV audits. This can be in many different ways. It can be that they want stricter timeframes for you to comply with a record submission. They can have repercussions if they think your coding or documentation isn't accurate. They can institute a corrective action. They can require that the provider undergoes training, education. Some plans have even attached penalties to noncompliance. We've actually seen some plans who have included language where they reserve the right to terminate a provider for recurring failures. But more than anything, the thing that we're seeing is an increased unwillingness to negotiate this language at all. In the past, sometimes we've been able to work with plans. Maybe they'll agree not to go back too many years. Maybe they'll limit the penalties. That doesn't seem to be the case anymore. There's definitely less wiggle room here. The plans are really nervous about being on the hook for all of this alone. So what's the bottom line here? I mean, it's kind of similar to what Deb was saying before. You can try to negotiate. Your success here is largely going to depend on your unique situation and your unique relationship with each plan. Beyond that, you got to make sure the documentation is there. And specifically, HHS actually identified four conditions where they're really focusing here. First is vascular disease, serious mental illness, COPD, and congestive heart failure. So if you have patients with those diagnoses, know that the plans are probably going to also pay closer attention to that. And with that, that's just make sure you keep an eye on that documentation, because they will be auditing. The plans want to make sure that they're not going to get dinged for this. And then with that, we can hop back over to David for voluntary disclosures.
Thanks, Allie. So, as I said at the top of the program here, one of the things I want you to take away from this is the importance of being, thoughtfully proactive. And by that, what I mean is, taking the opportunity, whether you're a plan or whether you're a provider, to understand sort of where your risk areas are, and take, proactive steps to sort of shore up any gaps that you might find in your policies and procedures or your compliance program or anything of that sort. And there's a reason for that, because as we've been saying, OIG's emphasis on this area, whether it's managed care for Medicare or Medicaid, it's going to continue to increase in the coming days and months and years. And so, one of the things that I like to talk about is, well, what happens if in doing some sort of proactive work on your own, you start to identify issues that may give rise to liability, either under the anti-kickback statute or the civil monetary penalties law. Luckily, our friends at OIG have given us sort of an off-ramp to handle these issues, and it's through their voluntary self-disclosure protocol that you can sort of resolve these issues while they're still small before they become bigger issues. If you follow me at all on LinkedIn, I know that some of you do. I recently put a post up about why it is that I love OIG's voluntary self-disclosure protocol. And the reason that I love it is because it gives providers an option, right? In life, it's great to have options. In particular, when you're dealing with the government, it's better to have options as well. And one of the things that the self-disclosure protocol gives providers is options. It's much better to report something to the government or to the OIG about some sort of shortcoming or misconduct if you believe that you have liability under the civil monetary penalties law. The OIG themselves want to incentivize providers to use the protocol, and they do that in a couple of different ways. But before I get into that, one of the things I want to sort of make clear is in the providers that we've helped go through the process, there's always sort of a concern that if they disclose an issue to the OIG, that the OIG is going to use that information to start poking around in sort of other areas. That's not what happens. Okay, if you find evidence of misconduct or wrongdoing or something that gives rise to liability, and you report that to the OIG, the sort of narrow issue that you're reporting, that's what the OIG is going to look at. Because if they have limited resources and they don't have the time to sort of use that as a fishing expedition to say, oh, well, this provider disclosed X, I wonder if they have a problem in Y also. Plus, like I said, they want to incentivize providers to use the self-disclosure program. And if you sort of turn around and use those disclosures to do deeper digging, I think that has a chilling effect that they don't want. So you might be asking yourself at this point, sort of like, what are the benefits of using the self-disclosure program? Well, first of all, it's open to anyone, any provider, as I mentioned, who could potentially be subject to civil monetary penalties And those are set forth in the Code of Federal Regulations at 42 CFR Part 1003. Right now, OIG has over 40 different CMPs or civil money penalties that they could pursue providers for. But the good news is that it's available to providers whether they're participating in Medicare or Medicaid, fee-for-service, or managed care. And there's really essentially a couple different disclosure protocols that they use. The biggest one really is for disclosures relating to healthcare fraud. They have separate disclosures for grant recipients and contractors and things of that sort. But the vast majority of the disclosures that come in through the protocol for healthcare fraud. And the benefits of doing it are many. Number one, the big benefit is if you self-disclose something to the OIG, you can resolve that matter without them applying additional integrity obligations on you. For example, whether it's a corporate integrity agreement or some other sort of integrity obligations. It's one of the ways in which they incentivize providers for using the self-disclosure protocol. If you use it, and they're not going to lay on additional integrity obligations. The other thing is that they offer a lower multiple to settle the matter. So typically under the civil monetary penalties law, the exposure to the provider could be up to 3 times the value of the amount claimed. Here, they incentivize providers to use the self-disclosure protocol by giving them the ability to settle the matter for a 1.5 multiple, not on the amount claimed, but rather on the amount paid, which could lead really to significant savings for the provider. There's also, in settling matters through the self-disclosure protocol, you also get a release for any permissive exclusions that they would maybe be able to pursue. So you would sort of dodge that bullet. And then lastly, it may also, participating in the self-disclosure protocol may also mitigate sort of any exposure that you might have under other actions or things that the government might be able to take. And here in particular, I'm thinking about the 60-day rule. For those of you who are not familiar with it, the 60-day rule basically states that once you learn of an overpayment, you have 60 days in which to identify the overpayment and repay that money back to the appropriate plan or contractor or to whomever it is that you owe that money. Since we're talking here about MA plans, as Deb mentioned, you'd be well served to look at your contractual obligations with respect to reporting overpayments. But it's also important to understand that the OIG has a 6-year look-back period. So again, as I think it was Ali who had mentioned, there's a lot of risk out there because it's not just OIG looking at potentially 1 or 2 years. It could go back for some period of time. So I say all these things because what I think that the OIG's idea is that if you have a compliance program that identifies these issues, OIG wants to reward you rather than penalize you for that, because it shows that you have a robust and functioning compliance program, and it shows that you're being cooperative with the government, right? And the OIG wants to incentivize those types of things. Lastly, you should know that there are certain single damage dollar thresholds that OIG requires to participate in the protocol. For example, if it's an issue involving a kickback, the minimum amount that they will look at is $100,000. For all other matters, it's only $20,000. So the bar, financially, is pretty low to be able to get into the protocol. So, with that, like I said, I can't sort of emphasize enough how important and frankly underutilized this this tool is for providers in particular to mitigate any potential CMPL liability.
David, can I ask you a question? We had a couple of questions come in while we've been presenting.
Yeah, great.
One, with respect to normal course of dealing with MA plans, typically, if an overpayment is discovered, often with managed care, there's due to and due from, and you kind of keep a tally, and then maybe hospitals will have, annual reconciliations with the health plan. Is that would still be acceptable to the OIG? In other words, this is like, we're noting that we have a potential credit. We deal with all these are typical, overpayments, underpayments, and reconciliations. Is that anything of concern? Should hospitals continue to do that? Or should they, if they've gotten an overpayment, they just need to return it? Is that, best practices?
Yeah, I mean, I think the best practice would be, obviously the contractual language of your agreements, may dictate to providers, how or the mechanism by which they go about returning overpayments. I would say sort of as a best practice, given the existence of the 60-day rule, you would be better served to, if you've identified an overpayment and you've been able to quantify it, then I think from my perspective as a former OIG attorney, you would want to report that to the OIG as quickly as you can. But I want to make an important distinction here, right? Because the self-disclosure protocol is meant for certain types of conduct that could give rise to liability under the CMPL. If it really just is sort of your garden variety overpayment without potential liability attached to it, then that's something that you would make the repayment sort of as you're directed to do so. Keep in mind that the protocol is meant for activities that give rise to liability under the CMPL. That being said, one of the provisions that people disclose under the CMPL is the knowing retention of an overpayment. So if you knowingly retain an overpayment after you've identified it and you've quantified it, you're putting yourself at risk potentially for CMPL liability.
Thank you. Also, another question came in that I just want to address. This one was what I spoke about. The question was, do Medicare Advantage plans have to pay CMS designated inpatient only as inpatient? I think if the questioner was talking about the list of, if it's on CMS's inpatient only list, if we're talking about that same list, which I believe we are, yes, it has to be paid as an inpatient. The question becomes, under your contract, are there any loopholes where it states that, we'll pay it as an inpatient? The question is, at what rate? I mean, health plans have been fairly aggressive over the last, 5 years or longer in terms of recoding. So if they think that you haven't coded correctly, they may change some of your coding and it may map out to a different DRG. So that could get in there. But if it's an inpatient, they can't down code it to observation or say, you have to, this was a level of care denial and you have to resubmit as outpatient. So no, they have to pay it as inpatient. And then you look to your contract as to how those inpatient admissions get paid. There was also just another question came in. Well, it flashed, but let me try one more time.
Deb, I think it's in the chat.
Chat now, yeah. I'm going to read it out. Does self-disclosure apply to overpayments that are due to retroactive coverage changes and not through any action of the provider? Meaning, at the time coverage was confirmed with, well, it says Medicaid, but let's just talk Medicare. 2 years later, notification is received that coverage was actually through a different plan.
So is the question about overpayments in situations where you've got some sort of a retroactive change?
Yeah, in other words, we thought, let's say we thought that it was, the patient was covered by, United, and it turns out it's an Aetna patient. And let's say it's Medicare, Medicare Managed.
Yeah, again, I think that to the extent that you have received an overpayment, right? That's sort of when you find evidence of an overpayment, your antenna should go up, right? And so there is a variety of different ways in which, providers or plans may, come to be in receipt of an overpayment. But I think sort of once that happens, then it's important to sort of do your due diligence to be able to say to yourself, all right, what was the source of the overpayment? How did we quantify it? How long was this going on? And you would look to see whether or not that was something that would give rise under, to liability under the civil monetary penalties law. So certainly, there's arguments to be made that if an overpayment is created through no fault of your own, that you would not have the requisite level of intent to be held liable under the civil monetary penalties law. So I guess my answer would be, I'll give you the sort of typical lawyer's answer is that it depends, right? It's a very sort of specific facts and circumstances analysis. But understand that under the civil monetary penalties law, if the government were to pursue a provider under that, they have to still establish that the provider had the requisite level of intent to violate the CMPL. And that means that they either had actual knowledge or that they were deliberately ignorant about the rules, or that they demonstrated a sort of a reckless disregard with respect to, the applicability of particular rules. So, you've got to sort of fit into one of those three categories to be held accountable under the CMPL.
If there are any other questions, we're happy to take them. You can type them in, or you can reach out to us. Our contact information, Allie, you want to just scroll? We have it in the back of the deck. There's mine, David's, and Allie's. So if any questions, reach out to us. We're happy to provide additional information if you need it. With that, thank you to my colleagues, David and Allie, and all of you for joining us today, and have a great day.